Hey, Pediatric team, let's talk hormones and health. Welcome to a deep dive into the incredible world of pediatric endocrinology. You brought us, well, quite a stack of vital information. It's a fantastic resource covering everything from how these little bodies manage growth and sugar right through to crucial nursing care strategies. Our mission today is really to unpack all this knowledge, pull out those essential insights, and hopefully help you feel truly informed on these critical topics we see impacting kids every single day.
Yeah, this material gives us a really comprehensive look, doesn't it, at the endocrine system in children, how things can go wrong, and the practical, hands-on approaches needed for care. We'll explore how interconnected these conditions are and really focus in on the key signs, the diagnostics, and those vital interventions.
Okay, so let's maybe start with the system itself, the endocrine system in kids. It's kind of like your internal regulator, right?
Yeah.
Especially for growth and development. It's managing just about everything: energy, blood sugar, fluids, sexual maturation, even how they handle stress.
And it does all that using hormones. The source calls them chemical messengers, which is a great, simple way to put it. They're made by these, well, tiny but really powerful glands: pituitary, thyroid, adrenals, pancreas, the list. And they travel in the bloodstream to tell specific organs what to do. The source mentions two main types: protein-based ones from amino acids and steroid hormones from fat.
It's a pretty sophisticated communication network. And
Yeah.
the way it stays balanced is through these feedback loops, right?
Exactly. Negative feedback tells a gland to stop making hormone when there's enough. Positive feedback signals it to make more when levels are low. It's all about maintaining that, well, that delicate balance.
Makes sense. And seeing when that balance is off, well, that starts with a really sharp assessment.
Absolutely. And for us as nurses, the source really emphasizes this is where we play such a key role.
Right. So the assessment, it kicks off with a deep dive into their history. You're gathering everything: prenatal details, birth history, past hospitalizations, current meds, allergies.
Family history, too, super important. Any endocrine stuff, extreme heights or weights in the family?
And you're looking at milestones, how they're doing in school, because these conditions can definitely impact learning.
And really detailed nutrition habits, not just what they eat, but how and when. Activity levels too, daily activity, sports, even screen time, it all paints a picture.
Then the physical exam. And this is where the source really hammers home the need for precision. Accurate measurements are just non-negotiable. Infant scales, calibrated, minimal clothes.
Right. And supine length for the little ones under 24 months, then a stadiometer for older kids, shoes off, heels to the wall, standing straight.
Head circumference under 36 months, check in those fontanelles too.
And like the source points out, it's not just getting the numbers, it's plotting them. Growth charts are absolutely essential. You're watching the patterns, but especially looking for those declining trends over, say, 6 to 12 months. That's a big red flag for a lot of these issues.
And there are calculations that help frame it too. Body surface area, mid-parental height gives you a genetic target range, remembering the boy-girl formula differences.
Yep, BMI and height velocity, that's a big one. How many centimeters or inches are they actually growing per year?
Beyond the numbers, the source reminds us. Check vitals, Tanner stages for puberty, watching for anything off there, ambiguous genitalia, or things happening too early or late.
Examine the skin pigmentation changes, weird body odors. Check the neck for goiters or nodules, muscle tone, strength.
Even facial features can be clues, right? Like a prominent tongue, bulging eyes, maybe extra hair or facial roundness that seems unusual.
Exactly. That thorough assessment gives you the foundation.
Okay, let's jump into some specific conditions, starting with the pituitary, the master gland.
Yeah, pituitary powerhouse. A big one is growth hormone deficiency, GHD. The source explains it's when the pituitary isn't making enough GH, sometimes other hormones too. Can be caused by head trauma, tumors, infections, chemo, or sometimes congenital.
So clinically, what are we seeing? The source mentions delayed growth, specifically less than, 2 inches a year after infancy. And that pattern of falling off their own growth curve, they might have a higher weight-to-height ratio, maybe more belly fat.
Yes, exactly. And in babies, maybe a delayed closure of that anterior fontanelle, the soft spot.
And for congenital hypopituitarism, the signs can be more acute.
Right. Frequent low blood sugar, maybe prolonged jaundice, small penis or testes in boys, lethargy, feeding issues. And the source makes a really critical point here. If a newborn has hypoglycemia because of this, they need GH replacement immediately. It can be fatal otherwise.
Wow. Other signs mentioned: Delayed teeth, decreased muscle mass, looking young for their age, that cherubic look.
Delayed puberty, high-pitched voice sometimes too.
So diagnosis.
Yeah.
Beyond those crucial growth charts, you mentioned the bone age x-ray,
Yeah.
left hand and wrist.
Yeah. If the bone age is way behind their actual age, like more than 2 standard deviations, that needs follow-up. An MRI of the brain, focusing on the pituitary, helps check for structural issues or tumors.
And you mentioned provocative GH testing being critical, not just one blood draw.
No, definitely not. Because GH is released in pulses, you have to stimulate it with medication and take multiple samples over hours to really see if the response is adequate. It's quite involved.
Got it. They also check IGF-1 levels, rule out other things like thyroid issues, celiac disease.
Right. And for us nurses, managing GHD means super careful growth measurements, tracking that trend. Assessing the psychosocial impact, too, is the child worried about bullying. What are the parents' beliefs?
And lots of education.
Huge amounts, especially on the home care. GH replacement is usually daily subcutaneous injections, often at bedtime. The source lists common brands like genotropin, humatrope.
Compliance is key, right? And follow-ups every few months.
Absolutely vital for it to work. Follow-up is usually every 3-4 months for dose checks. Parents need to know about potential side effects like headaches or joint aches, especially when starting. Starting early gives the best chance for maximizing height.
Okay, flipping that coin. Hyperpituitarism. Too much hormone, usually excess GH from a tumor. Gigantism before growth plates close. Acromegaly after.
Yeah, you see really dramatic, uncontrolled growth, way off the charts, above the 95th percentile. In older kids, enlargement of hands, feet, coarser facial features, jaw, forehead, muscle weakness, pain, maybe even early puberty if the tumor is pressing nearby.
Diagnosis involves tracking that crazy growth, checking IGF-1 levels, seeing an advanced bone age, and MRI for the tumor.
Nursing care is about monitoring growth, assessing for those physical changes, labs, and then if surgery's the route, lots of pre- and post-op care. Neurochecks, vitals, watching the site, complications.
And caregiver education, again, understanding the disorder, treatment options, maybe ongoing meds even after surgery, and why compliance matters to avoid long-term heart issues, diabetes, sleep apnea, serious stuff.
Okay, let's shift from growth to water balance. Mostly controlled by ADH from the posterior pituitary. The source focuses on 2 opposite problems here.
First, diabetes insipidus, DI. Not enough ADH, or the kidneys ignore it. Central versus nephrogenic often starts suddenly.
Yeah, abrupt onset. And the classic signs are massive thirst and massive urination, polyuria, and polydipsia. Kids might start wetting the bed again, wake up all night needing water. Infants can be super irritable, only calmed by water, not milk. Fever, constipation, dehydration signs too.
And the source has a critical alert about dehydration, right?
Headache.
It can happen fast and be severe, especially in little ones.
Extremely fast. You're looking for dry mouth, sunken fontanelle in babies, tachycardia, no tears, poor skin turgor. Severe dehydration is an emergency, needs IV fluids right away to prevent shock.
Diagnosis often starts with a 24-hour urine collection, just measuring the sheer volume. Labs show high serum sodium and osmolality, but the urine is dilute, low osmolality.
And the water deprivation test is key, as the source details. Under close supervision, you restrict water, monitor weight, vitals, collect samples, see if the kidneys can concentrate urine as they get dehydrated. Needs very careful nursing oversight.
There's also that important safety note from the UK about desmopressin emissions causing harm. Key points. Dosing is individual, never restrict fluids unless it's the test, formulations aren't interchangeable, and strict monitoring is vital.
Absolutely. Nursing interventions focus on differentiating central versus nephrogenic, managing that test, giving meds correctly, often desmopressin, DDAVP, intranasally or orally for central DI, and relentless INO monitoring.
For home care, know the dehydration signs, go to the ED, increase fluids during illness, medication compliance, knowing how to give it, having a backup plan for nasal congestion. School needs to know, medical alert bracelet.
And a crucial point, vasopressin or DDAVP won't work for nephrogenic DI because the kidneys aren't listening. So getting the diagnosis right is critical. They might need diuretics or other meds instead.
Got it. So the opposite problem is SIADH syndrome of inappropriate ADH, too much ADH.
Right. Body holds on to way too much water, leads to water intoxication, dangerously low sodium hyponatremia and cell swelling. Can happen with infections, lung issues, post-op.
Symptoms are often tied to that low sodium, nausea, vomiting, crucially, seizures.
Yeah, seizures are a big risk. Also personality changes, confusion, headache, maybe high BP, lung crackles. They might gain weight but not look swollen. Urine output is low and concentrated.
Diagnostics show low serum osmolality, high urine osmolality, high urine sodium, and that key low serum sodium, the source says, often under 125 in severe cases.
Nursing care. The number one thing the source highlights is fluid restriction. Absolutely essential. Maybe 75% of maintenance, then down to 50% if needed.
Severe symptoms, neuro changes. That needs hypertonic saline urgently. Maybe stress dose steroids if there's adrenal insufficiency too.
And again, meticulous I&O. Every single drop counts. Think hidden sources. Strict diaper weights for babies. Give meds with meals. Oh, and irrigate feeding tubes with normal saline, not water, to avoid washing out sodium. Encourage high sodium, high protein foods.
Neurological assessment is critical. Watching for altered LOC is a sign of seizure risk. Seizure precautions.
Caregiver education for SIADH. Recognize those emergency signs of low sodium weight gain, confusion, irritability, headache. Get to the ED. Importance of fluid balance, I&O, hidden water sources. High sodium protein diet, medical alert bracelet.
And that critical point again, low sodium, especially under 125, means high seizure risk. Keeping sodium stable is the goal. Our role in I&O and weights is huge there.
Definitely.
Okay, moving on. Puberty. Precocious puberty starting too early. Before 8 in girls, before 9 in boys. Causes can be complex, premature brain signals, or other hormonal issues.
Assessment using Tanner staging is key. You're looking for early breast development, testicular growth, pubic hair, acne, all appearing sooner than expected.
Diagnosis, bone age x-ray, again, it'll be advanced. Labs check sex hormones. And those provocative GnRH stimulation tests to see if the brain signals are firing early.
Nursing focuses on early ID and treatment. Tracking growth velocity shows if treatment's working. Assessing Tanner stage changes. A main treatment the source mentions is GnRHA meds, like leuprolide acetate lupin, usually monthly injections to pause puberty progression.
Caregiver education sounds multifaceted here, explaining the condition. The source notes those benign variations like just breast buds or just pubic hair need watching, but maybe not full treatment.
Right. Helping parents navigate social stuff, dress the child age appropriately. Stressing medication compliance to maximize final height.
And talking about sexuality earlier, protection, because they might look older.
Right.
Importantly, the source says GnRHA treatment does not cause infertility. Puberty just picks up where it left off when the meds stop.
Good point. Okay, thyroid and parathyroid. Metabolism and calcium control. Hypothyroidism, underactive thyroid. Congenital is caught by newborn screening, which the source calls absolutely key EY. Acquired can happen later, often Hashimoto's autoimmune.
Congenital signs aren't always obvious at birth, right? Develop over weeks. Floppy baby, lethargy, jaundice hangs around, poor feeding, big tongue, umbilical hernia, constipation.
Yeah, and the source is really strong on this. Immediate treatment is vital to prevent cognitive damage. Cannot wait.
Acquired hypothyroidism in older kids. More classic low metabolism symptoms. Fatigue, cold, dry skin, constipation, maybe gaining weight despite poor appetite, slowed growth, delayed puberty, maybe a goiter. School performance can dip.
Diagnosis is that newborn screen. For acquired, labs show low T4, high TSH, growth velocity slows, bone age is delayed.
Nursing care for newborns, make sure that replacement starts right away. For all kids. Track screening results, assess growth, activity, bowels, and huge emphasis on medication education.
Yes, usually levothyroxine. Teach parents to crush it. Mix with a small amount of liquid or baby food, not the whole bottle. Avoid soy formula unless dose is adjusted. Same time daily, usually morning. Lifelong compliance. No signs of too much or too little.
The source mentions myxedema briefly, severe untreated hypothyroidism. Rare but dangerous.
Very rare in kids now thanks to screening, but yes, severe edema, metabolic collapse, hypothermia. Life-threatening if it happened.
Okay, the opposite. Hyperthyroidism, usually Graves' disease. Overactive thyroid, most common in teens. Untreated leads to complications and risk of thyroid storm.
These kids seem revved up, high T4, T3, but the TSH is LOW, or undetectable because the thyroid's gone rogue. Common signs. Goiter, maybe bulging eyes, exophthalmos, fast heart rate, high BP, sweating, increased appetite but often losing weight, primers, sleep problems, mood swings, irritability. Girls might miss periods.
Diagnosis confirms the hormone levels. Nursing care involves a thorough history school, sleep, mood, menses, regular follow-up, knowing the meds, antithyroid drugs to block production, beta blockers for symptoms. Watch for side effects of antithyroids like low white counts.
Caregiver education. Compliance, side effects. Educate the school about physical emotional changes. And critically, recognize thyroid storm signs, rapid worsening of symptoms, get to the ED immediately. A calm home environment helps.
Got it. Parathyroids, next tiny glands, big job with calcium via PTH. Hypoparathyroidism is rare, not enough PTH, leads to low calcium.
Signs can include vomiting, poor teeth, headaches, confusion, and importantly, seizures and muscle spasms face, hands, arms, feet. Babies might be irritable, rigid, have apnea spells.
Diagnosis: low serum calcium, high phosphate, low PTH. ECG shows a prolonged QT interval.
Nursing care. Watch for spasms, twitching. Know the meds, calcium, vitamin D. Check I5 calcium sites carefully. Seizure precautions until calcium is stable. Cardiac monitoring often needed. Dietary advice, avoid caffeine. Push calcium vit K foods.
That clinical tip, Schwastek sign, tapping the facial nerve. Good way to check for muscle excitability from low calcium in little ones.
Yeah, it's a helpful bedside sign.
Caregiver education, lifelong management,
Yeah.
dietary compliance, calcium vit D often lifelong, give with acidic drinks, no signs of low calcium.
Hyperparathyroidism, too much PTH, high calcium. Also rare, more common in teen girls.
Classic signs: feeling awful, constipation, dehydration, headache, vomiting.
Correct.
Cardiac issues are key here. Heart block, shortened QT interval, opposite of hypo.
Other signs, bone pain, fractures, weakness, kidney stones, thirst, urination, mood changes.
Nursing often involves post-op care if a gland is removed. Airway is number one. Monitor the site, fluids, electrolytes.
Caregiver education, post-op, incision care, nutrition, but crucially, recognizing signs of hypocalcemia, low calcium, because taking out an overactive gland can cause levels to drop. Calcium and vitamin D are often lifelong supplements afterward.
Okay, adrenals. On top of the kidneys, cortex makes steroids, medulla makes adrenaline and catecholamines.
Right. Let's start with Cushing's disease, too much cortisol. Can be tumors, or often in kids from chronic steroid medication use. Diagnosis can take time.
What does it look like? Mood changes, but also growth delay despite weight gain. That round moon face, flushed cheeks, buffalo hump, fat pad, belly weight gain, stretch marks, striddy, high blood sugar, high blood pressure.
Diagnosis uses 24-hour urine tests for cortisol, dexamethasone suppression tests, saliva cortisol tests, imaging like MRI or CT.
Nursing care depends on the cause. Meds to inhibit cortisol, radiation, surgery. Pre-post-op care involves fluids, pain, close assessment. Monitor electrolyte.
And here's a huge safety note from the source, vital for caregivers. If treatment drastically reduces cortisol, especially surgery, lifelong cortisol replacement is essential. Without it, risk of fatal adrenal insufficiency.
So they need to learn emergency stress dosing, injectable hydrocortisone for illness, fever, vomiting, trauma.
Absolutely. They need to know the signs of adrenal insufficiency, irritability, headache, confusion, nausea, vomiting, diarrhea, fatigue, and know it's a 911 emergency. Reassure them that Cushing's appearance improves with treatment.
Then there's congenital adrenal hyperplasia, CAH, genetic inability to make cortisol, sometimes aldosterone too, leads to adrenal overgrowth and excess androgens.
How it presents differs. Males, maybe later childhood with early puberty signs, fast growth. Females, often at birth with ambiguous genitalia. Enlarged clitoris, fused labia can look male, but internal organs are female.
Diagnosis starts with newborn screening. High levels of 17-OHP precursor hormone. Chromosome test confirm genetic sex.
Nursing priorities, early diagnosis, genetics referral. For infants, watch closely for dehydration, electrolyte imbalance, the salt wasting crisis, which is life-threatening, cardiopulmonary monitoring, and huge psychosocial support for parents dealing with the ambiguity. Refer to the infant as your baby until gender identity is clear.
And critical caregiver education again. Lifelong medications, corticosteroids, hydrocortisone, and often mineralocorticoids, Florin F, and emergency stress dosing, double or triple hydrocortisone for illness stress. No adrenal crisis signs, emotional support, CH groups, education if surgery for genitalia is planned.
Adrenal insufficiency, Addison's disease, not making enough cortisol and aldosterone, cause often unknown, hypoglycemia risk during stress, symptoms mild and less sick.
Signs: weakness, fatigue, dizziness, fast pulse. That distinctive dark skin pigmentation, black freckles, weight loss, dehydration, intense salt cravings, nausea, vomiting, low BP.
Diagnosis, low sodium, high GH potassium, low blood sugar, low BP, low morning cortisol confirms it.
Source repeats: lifelong hormone replacement needed. Kids might grow poorly but have normal puberty. May need GH too.
Addisonian crisis is the emergency. Severe weakness, vomiting, diarrhea, bad abdominal pain, dehydration, shock, low sugar, LSC changes, immediate medical help.
Nursing: frequent labs. Give corticosteroids, oral or IM Solucortef if NVD. Strict INO, hydration. Teach families that home emergency IM injection.
Caregiver education focuses on that emergency readiness. Crisis signs, how to give IM Solucortef. Medication compliance is paramount. Skipping doses invites crisis. Medical alert bracelet always. Stress dose education, hydration for activity, increased salt in warm weather.
Last adrenal one. Pheochromocytoma,
Yeah.
rare tumor, adrenal medulla, pumps out excess catecholamines, adrenaline, peaks, 6-14 years.
Symptoms: high heart rate, headache, palpitations, dizziness, poor weight gain, growth failure, maybe sweating, abdominal pain, thirst urination.
Diagnosis: 24-hour urine for catecholamine metabolites, MRICT for tumor location.
Nursing: pre-OP meds, alpha beta blockers, for 1-3 weeks to control BP before surgery. Careful vital signs, especially BP, monitor blood glucose, quiet environment post-op, and the critical safety point for Pheo: do not palpate the abdomen over the adrenals. Can trigger a massive catecholamine release, causing hypertensive crisis or arrhythmias. Big no-no.
Wow. Okay, huge topic next. Diabetes mellitus, type 1 and type 2.
Right. Type 1 T1DM, autoimmune destruction of pancreatic beta cells. No insulin produced. Need injected insulin to live. Genetic links, maybe viral triggers.
Classic presentation. The 3 Ps, polyuria, polydipsia, polyphagia, excessive peeing, thirst, hunger, but unintentional weight loss despite eating, high glucose and blood nausea, fatigue, more infections.
Diagnosis: confirm high BG twice, fasting 126 or random 200 with symptoms. A1C 6.5%, low insulin levels. Often positive autoantibodies confirm T1DM.
Nursing interventions are broad. Assessment, insulin administration, double-check orders, second RN verifies dose, correct type strength, only insulin syringes, rotate sites, only regular insulin IV for DKA.
Daily weights guide dose changes. Sliding scale needs BG checks before meals and at bedtime. Diet education is huge. Dietitian consult for carb counting is ideal.
Exercise needs planning. Right. The source stresses that pre-exercise snack, complex carb and protein 30-60 mils before to prevent lows.
Critical education.
Yeah.
Recognizing and treating hypoglycemia, low BG, and hyperglycemia, high BG. Source lists symptoms clearly.
Pale, sweaty, shaky, confused, irritable. Check BG if 70 and conscious.
Yeah.
Rapid carbs, juice, glucose tabs, recheck 15 millids. Unconscious seizing, glucagon injection. Know the dose.
Hyper. Tired, thirsty, dry mouth, peeing a lot, weight loss, maybe deep rapid breathing, because small. Foodie breath, check BG, check ketones, extra insulin if directed, push water. 2 tones plus high BG, seek emergency care.
Sick day rules are vital. Monitor BG often, don't stop insulin, adjust maybe, check ketones, be careful with OTC meds, have a plan, force fluids, the MDC-BHF mnemonic helps.
BG monitoring multiple times daily, finger sticks or CGM. Ketone checks when sick, high BG, clinic visits, review logs, A1C gives the 3-month average, check electrolytes too.
Psychosocial support is essential. Referrals to ADA, JDRF, support groups, counseling.
Caregiver education covers it all. Insulin injection technique, hyper recognition and treatment, sick day rules, BG monitoring proficiency, ketone testing, glucagon use. School staff need training too.
DKA diabetic ketoacidosis, life-threatening. Defined by hyperglycemia, 200, acidosis, pH 7.3 at bicarb 15, ketones, often triggered by missed insulin, illness, pump issues.
DKA nursing complex, 5E fluids, NS usually, IV regular insulin infusion, correct acidosis, electrolytes, monitor labs, BG, vitals frequently, assess for Kussmaul breathing, fruity breath, careful IV management.
The source notes risks for pregnancy with diabetes, preconception counseling from puberty is recommended for girls by the ADA.
And technology helps management, pens, pumps, basal bolus, sensor augmented pumps in your enclosed loop, self-monitoring, finger stick or CGM is crucial for anyone on insulin.
Okay, lastly, type 2 diabetes, T2DM, insulin resistance plus declining beta cell function. Rising incidence in kids linked to pediatric obesity. Earlier onset means faster progression.
The source provides risk-based screening criteria. Puberty or age 10 if BMI, 85th percentile, PLOS risk factors like family history, maternal history, race, ethnicity, or signs of insulin resistance.
What are those signs of resistance?
Acanthosis nigricans is a big one. Those dark, velvety skin patches on neck, armpits, also hypertension, dyslipidemia, PCOS.
Presentation varies. Might have classic P symptoms, might be asymptomatic, might have ketones, gradual signs, foot burning, poor wound healing, vision changes.
Diagnosis uses same BGA1C criteria as T1DM. OGTT200 also diagnostic. Antibody tests help differentiate.
Nursing interventions, give meds, antihyperglycemics or insulin. Treatment foundations, diet and exercise. Metformin is usually first-line med if over 10, good kidneys, A1C 8.5%. No dosing, contraindications, lactic acidosis risk, hold for contrast. Insulin, if BD, very high. Liraglutide is another option.
Dietitian referral is key. Encourage exercise, maybe PT referral. Assess for psychosocial issues like body image, depression.
The source highlights childhood obesity stats and risks. Reducing obesity is prevention and treatment. It's complex, but involving the whole family in healthy eating and activity is critical.
Yep.
Home and screen time. Educate on long-term T2DM complications, vision loss, CVD, kidney disease.
Caregiver education for T2DM, diet exercise compliance is central. It's a team effort. Teach about meds, hyper DKA signs, less common DTA, but possible.
Well, that's a huge amount of interconnected information. Diving into pediatric endocrinology really shows you just how complex these systems are and the challenges kids can face. What really stands out looking at all this is that incredibly vital role of accurate assessment and knowledgeable, supportive nursing care. It weaves through absolutely everything.
Absolutely. Whether it's picking up subtle signs of congenital hypothyroidism or knowing how to handle dehydration fast in DI, managing fluids carefully in SIADH, or teaching that emergency stress dosing for adrenal issues, guiding FAMTIV through the daily maze of diabetes management, our ability to assess, educate, and intervene based on this knowledge is just paramount.
Right. It's about empowering families for what are often lifelong conditions managed mostly at home.
Exactly. Ensuring kids get the right care at the right time. That caregiver education piece is threaded through every single condition for a reason.
So consider this. The profound impact that early identification and consistent knowledgeable support has, not just on a child's physical health, which is huge, but on their confidence, their ability to be kids, go to school, play sports, really their entire future. How can we, as healthcare systems and communities, better support families navigating the sheer complexity of these chronic conditions? Something to think about.
Balance is everything. See you in the next one.